That is what I was telling you, because there is no kidney over here. So that is why we do not have this anterior pararenal space and the posterior renal space in the lower level at L3, L4, L5, L5 is 1 level. Now, as we cross these muscles, we cross this fascia, then we go towards the foramen. So intervertebral foramen, as we all know, we have been practicing transforaminal for the neuroplasties, but there we are targeting the nerve root through this approach, suprarenal approach. That means just below the pedicle and between the pedicle and the nerve roots. So that is a transforaminal approach what we use for this transforaminal neuroplasties. But for endoscopy, we have to go below the nerve root, that is in the Cambrian triangle, which is over somewhere over here. So this is basically bounded by, we all know about this intervertebral foramen, which is bounded anteriorly by the vertebral body here, and the intervertebral disc over here. The nerve root lies in the upper part of the foramen, and posteriorly it is covered by this facet joints, superiorarticular and infraarticular process over there. Superiorly, there is an infrapedicular notch. That's an infrapedicular notch of the superior vertebra. That's an infrapedicular notch. And this is the suprapedicular notch of the inferior vertebra. That's the suprapedicular notch of the inferior vertebra. So this is all covered with the surrounded by the bony margins. We have all the bony margins around this, and you can see them clearly on the MRI. So if there is any foramen herniation, we can see on the sagittal sections. If we just had to follow the sagittal sections, so sagittal sections, when we see them from extraforaminal area, and then we start going towards the foramen, then we start going towards the paracentral area, then central area, and likewise we can go to the other side and we can start seeing the entire roots over there. So whatever we are seeing here in the foramen is the exiting root over here. So that's the exiting root over here. Okay. And as we go towards more medially, you can see here that this section is taken from the foramen area. So you can see all this clearly. So if there is a foramen herniation, you may be able to see this foramen herniation over here in this section. As we go more medially, you can see here this density taken from the foramen area. Then you can see all these exiting roots over here, and the disc, they are not bulging, they are not coming into the foramen area. The foramen is completely free. So this also gives you this idea that you have good enough space available to enter into the foramen. There is your exiting root lies, and how safely you can go inside. At times, you may know that there is some facetal hypertrophy or the ligamentum flavum, which is maybe going inside and encroaching into the foramen, or maybe the facetal hypertrophy is there that may be pushing this facetal joint inside. Or at times there's some inflammatory pathology, and that pushes the supraarticular process or the infraarticular process inside. In that case, you may be able to see that your foramen space is narrow. So you have to be careful in those cases, because in that cases, there are chances of injuring the nerve root or compression of the nerve roots. So all these things we can see in the sagittal section when we take the multiple sections. As we go medially towards, more medially towards, we can see this. Now we can see here the traversing roots. Now we have gone inside the foramen, we have crossed this middle border pedicle, and we are entered into the canal. So when we enter into the canal, into the paraspinal region, we can start seeing these traversing roots over here. So if it is a paracentral herniation, in that case, we can see this herniation over here, and we can see this either it is compressing or pushing the nerve roots on one side. So you can see all these traversing roots over here. So I think we all know what is traversing root, what is exiting root. I'm not going to those basics, but still, if you have any query related to that, we can ask also. Don't feel shy about that. Okay. Is this clear? You can see, can you all see these sagittal sections? Can you make out these sagittal sections? Can you see this traversing roots over there? Okay. Why we are calling it traversing roots? That is clear, right?
Yes, sir.
Good. And as we go towards the center, now we can see this spinal cord ending over here, and you can see the bunch of the nerve roots, because all the nerve roots are initially in the center. Then when they start going towards their respective foramen, they start taking the exiting from there. And you can see here, and now we are going on the other side. and we can see the foramen on the other side, and you can see this exiting root of the other side. So this way we can also see in the sagittal section, we can see whether it's a foramen herniation, central herniation, paracentral herniation, all these we can see, and what is the relation with the exiting root and the traversing root. All these we can see on the sagittal sections also. You can see here, this is a good example of the absolutely foramen herniation. Let me tell you, most of the time, you may not see such kind of absolute foramen herniation. Most of the time, it happens that we have a paracentral herniation, and which is extending into the foramen. So paracentral extending into the foramen, that is the most common type of herniation. If it is absolutely foramen herniation, you can see here on the sagittal section, when the section is taken from the foramen, like this from here, we can see this bulging disc over here. And basically what is happening, it is pushing the nerve upwards. It pushes the nerve upwards. So the nerve is already compromised over here. When we try to remove this material, we should be very particular about only targeting this foraminal herniation instead of starting and going inside the disc. This is what most of the time people do. They just go inside the disc and start removing the disc material from there. But it is very important for us to understand where is the herniation, what kind of herniation it is, whether it is migrated upward, downwards, and accordingly we should select our trajectory. So this all we'll cover during our successive sessions when we discuss about the transformal approach, other approaches. I'm just telling you right now what all you must see there. So if you have like a foramen herniation like this, and if you try to go inside the disc, what will happen? You can imagine that you are putting your scope, you are putting your working channel. There's already the nerve is compromised, and your extruded the material is lying over here and removing the material from here. Uh, and it will come. It will basically compress the nerve root for longer time. And even if we do a good decompression over here, patient will come with the similar complaints, or maybe patient may come with the paresthesia or maybe some paraparesis also, because that is nerve root is severely compromised over here, and you are putting the scope inside. So you must understand these where is the herniation lies. Uh, Foramen, as we know that the anatomy of the foramen, we all know about the anatomy of the foramen. It has two parts basically, the mobile part and the fixed part. This is almost the fixed part, the upper part of the foramen, which is bounded by this inferior particular notch, the vertebral body, inferior process over here. And the lower part is basically the mobile part, which is by the facet joints posteriorly, anteriorly with the disc over here, and this is the supraparticular notch. So this basically we divide into two parts: the mobile part and the fixed part. Uh, Fortunately, this nerve root lies in the fixed part, and most of the degenerative process, whatever happens, they are happening in the lower part of the foramen, whether it is a facetal hypertrophy or it is a disc herniation. All these are happening in the lower part of the foramen. So it is a good idea whenever we're doing transformal endoscopic discotomy, it is a good idea to have this X-ray also, especially in the old age patients where we have a lot of degeneration of the spine. In those cases, we can also go for the X-ray to see the foraminal area, what is available with us. If you have a very tight foraminal, it is very difficult to go inside. In that case, you may have to go for the foraminotomy first, and then you can go inside to remove the disc material. So you should have this X-ray available with you. If there is a lot of degeneration, if you can see on MRI, degeneration is there. The practice depends on most of the countries, they have different practice. Like in India, the practice what we have is that uh, normally we don't go for the X-rays. If the patient is having severe radicular pain or some radiculopathies are there, in those cases we don't go for the X-rays first initially. We straight away we go for the MRI, because we have these facilities available. We can, if the patient comes to me right now, I can send the patient for MRI, and the patient is back with MRI films in just 1 hour. So if we, but most of the countries, they don't have this kind of facility. Usually they go for the X-ray and then go for the MRI. So even if you have this MRI available with you, and if you see that foramen is not good, or if you see that foramen stenosis is there or the degeneration is there, in those cases you must go for the X-ray to see that the area of the foramen. Dr. Datta, are you there?
I'm here.
Sir, if you want to contribute something, sir, in between.
Sure. Sure. No, I think your lecture is going great. So I will, I will give some input when,
Okay,
when I need.
sure, sir. Sure, sir. So, like I think, like in US, like what is your practice, sir? Like you go for the straight for the MRI, or you usually go for the X-ray first and then.
So a lot of our care is dictated by our insurance companies. So we don't necessarily need to get an X-ray all the time,
Okay,
but some of the insurances will need to have you get an X-ray first before you get an MRI. So
yeah,
we usually do get an MRI X-ray before the MRI. Yes.
okay. So that is a good advantage here in India that we can go straight for the MRI. We don't have to ask the insurance companies also for that. Because the insurance company, whenever they approve some endoscopic procedures, they want to have the MRI report first. Then only they approve. So that is some variation in the practice is also there. Okay. Anyway, this is the foramen height. Basically, if you can see this almost similar at all the level. If you can see here from L1, L2 to L3, L4, it is almost 17 to 18 is the height of this foramen, and the average AP diameter of this foramen is around 7 to 8 mm. That is from the anterior to posterior, from the antevertebral body to the facet joint. So this is what I was telling you,
So
Shirish.
I just want to make a quick comment about that. So the most of the scopes, the outer diameter is 7.5 millimeters. So you can see that, if you put in a scope in the bottom part of the foramen, it's really tight.
Yeah. So that is why most of the people they prefer this going in out. Sorry, half in half out technique also. So if there is a stenosis over there over the foramen, in that case, it is better idea to go for the foramenotomy first. You can just shave it off the facet over here, and then you can go inside. So that is also one technique which can do. Or some people they what they do is they just go inside the disc. That is inside out technique and outside in technique. Even if it is outside in technique, some people they prefer they go into the half in half out technique. So with that, you are taking you are basically half of the scope is working challenge is inside, and you have a good space over here. So Shirish, this is what I was telling you. When you go for the flexion of this, there's a increase in the height and the width both. So that flexion basically opens up the foraminal space. So that basically helps in basically opening the space, and you can go easily inside the foramen.
Yes, sir. Yes, sir.
So there are multiple ligaments also there in the foramen. You can see here there are a lot of ligaments which are there. There was a controversy regarding whether these ligaments may cause entrapment of the nerve roots or not. There's still some controversy. Some studies say that yes, this may be also the cause of the radicular pain. At times we see that patient doesn't have much of the herniation, much of the compression, but the patient's symptoms are too much, which are showing that there is some compression or the nerve root entrapment is there. So probably these are the ligaments which are responsible for that. But yes, definitely we see clinically these kind of entrapments whenever there's a listhesis. Listhesis definitely you may see there's hardly any compression, maybe grade 1, grade 2 listhesis, nerve root is not compromised, but the patient is symptomatic, too much symptomatic. So these are the probable causes of these entrapment. These ligaments are the causes in listhesis where these nerves, the ascending roots may get entrapped into the ligaments. Uh, uh, we have done some cases of this listhesis patient, grade 1, grade 2 listhesis. I don't know, Dr. Datta, are you doing
Yeah.
this or not? But we.
So the listhesis thing, I do quite frequently. Actually, I am going to discuss it, in subsequent lectures.
Yeah.
But listhesis can be managed by a variety of techniques. Grade 1 and grade 2 you can manage, but more than grade 2, they should have some sort of a stabilization.
So even we have this lecture on the
Right.
endoscopic fusion also, endofusion. We have a lecture on that also. So we are going to discuss for the listhesis also. But what I was telling is that for grade 1, grade 2 listhesis, when we see there is hardly any compression of the nerve roots, uh, because at times what happens is that whenever we have this grade 1 listhesis, we also have some pseudo bulging of the disc. So yesterday only I did one patient. She was 83 years old female. She was having grade 1 listhesis. She was having severe radicular pain. On MRI, it was not showing much of the compression. Some pseudo bulging was there. So I just did this endoscopically. I just went inside the foramen, and we could see a lot of ligaments which are basically growing crisscross, and probably they were compressing the nerve root. I just cut those ligaments, cleared some part of the disc material from there, and the patient was having absolute pain relief the moment she came out of that. Before the procedure, she was in terrible pain, and she was 83 years old. Obviously, she was not. They were not willing, and she was also not fit for the surgical decompression and the surgical fixation. So this is what we can also do for these kind of patients. So this we must remember about the ligaments. When you go into the foramen, you may see these kind of ligaments also. You it is always better to just go negotiate with these ligaments without cutting them. You just go and negotiate with the ligament and go inside. There are multiple vessels we are also worried about when we go for the endoscopic dystotomy. We are also worried about the bleeding part. So we must know what all vessels are there around the foramen and inside the canal. So these are the vertebral venous plexuses. We all know about these vertebral venous plexuses which are there, the internal ones and the external ones. So these are two sets of the venous plexuses, external. Also, there's a anterior and the posterior external venous plexus, and the internal venous plexus, which are vertebral venous plexus, which are again two sets of this internal venous plexus, which is anterior and the posterior. What is important is that these are the valves. Somebody is not muted. Please mute yourself. Please mute yourself. Okay. So these venous plexuses, as we know that the internal venous plexuses, these are valveless, and what we are worried about these venous plexuses is that one is the bleeding part, and another is that the absorption of this the fluid, whatever the irrigation fluid what we use. So these are the two areas where we are worried about that. Uh, since these have a valveless communication is there, and they're basically communicating with the occipital and the basilar sinuses over there. Uh, at times, whenever it gets prolonged, that time patient may complain of some neck stiffness or some headache or some sort of complaints. So that basically indicates that the pressure is very high and there's a lot of absorption which is happening with these venous processes, and there will be some increase in the ICP. Intracranial pressure may increase because of this absorption of the excessive fluid. So you should be aware of these kind of complications also. Also, we have these internal venous plexuses. If you see, we are having some longitudinal and horizontal. So what is the difference between these? These are very interesting to know that these longitudinal venous plexuses which are there, they are around this dura over there, and the posterior longitudinal ligament. They have some trabecula inside, and which is composed of some collagen fibers and the smooth muscles. So these trabeculae basically prevent the over-distension or the collapse of these vessels. And these are having some channels communication with these basivertebral veins. So at times when we go inside too much deep inside, when we start removing some disc material from there, at times we may see that suddenly there's a bleeding will start and it is very difficult to control. So this is because of the trabeculae which are there, they prevent this collapse of these vessels. Whereas most of the bleeding which happens, which is happening in the foramen area, fortunately, these vessels, they do not have this trabeculae in their walls, so they collapse. They usually collapse. Okay, and they also have a distension. So this distension and collapse, they have advantage also, disadvantage also. So they are vulnerable to distension, and that contributes whenever there's a herniation, there may be some engorgement of these vessels. They cause a distension of these vessels, and that may contribute to the radiculopathy of the patient. The fortunate part is that they usually collapse. So whenever we do foramen clearing and then we go inside, when we come out, there is a less chances of the formation of the epidural hematoma, because these, when we come out, they usually collapse on their own. So that is the advantage of these veins having not have a trabecular patterns. So these are the vessels which are responsible for the bleeding. At times we can see when we go inside the foramen, you can just coagulate them very easily. Uh, the bleeding which comes from the bones, like from the vertebral bodies or from the facetal, they are at times, because they are very minor, they are very trivial bleeders, but they usually trouble you a lot. But you can just increase the pressure of the fluid and you can just rotate your working channel to block these vessels. That is what maneuver you can do. All these things, techniques and troubleshooting, we can discuss during our technical considerations. We all know about these segmental arteries. The segmental arteries which are supplying the spinal cord, they are the reinforcement arteries for the anterior spinal artery and the posterior spinal arteries. The cervical regions, they come from the deep cervical, thoracic region from the intercostal, lumbar arteries coming from the diaphragm from the aorta, and the sacral intercoccygeal arteries from the lateral sacral arteries. Now these are important for us. These may, although rare, but this may become a source of the bleeder, which at times is difficult to manage also. So these are the segment arteries or the lumbar arteries. They divide into, basically they have three branches: the median branch, the middle branch, and the lateral trunk. So the median trunk, which basically, this is the median, this is the middle, and this is the lateral trunk. So the median trunk is one which gives the spinal branches and the ganglionic branches, which goes along with the nerve root inside, and it supplies the anterior posterior spinal arteries. The middle trunk gives one dorsal branch over here, and one anastomotic branch. This one, you can see here, this is dorsal branch over here, and this is an anastomotic branch which goes. So the importance is that this is anastomotic branch, or the communicating branch, which goes through this Cambian's triangle. This is the branch which goes through the Cambian's triangle. Mostly this lies in the posterior part of the Cambian's triangle over here. That means more anteriorly. If you see this as a Cambian's triangle, this lies more anteriorly, whereas our target is mostly, we target over here. So this is the safest area to land over here. If you go too much anteriorly over here, we may encounter this vessel. There's no lumbar artery in the L5 spinal branch. It is basically the iliolumbar artery, which comes directly from the interiliac artery. So this is what it is written here, that at the time of the puncture, the right angle near the inferior superior articular process is the most safe zone where we can enter here. Inside the foramen, we know that there's a spinal artery and the spinal branch and the ganglionic branch. The spinal branch which goes along with the nerve root and enters the spinal canal, and this is the ganglionic branch over here. Once this spinal arteries, the branches which goes inside, the segmental arteries, basically they divide into three branches: the medullary branches, which supplies the anterior spinal artery over here; the pile branches, which goes and supplies the basically these are the reinforcement branches, which supplies the posterior spinal arteries, so arteries supplying the arteries; and there are the radicular branches, which supplies the roots of the nerve roots over here. So this is the arrangement of the arterial system within the foramen and inside the canal. Most of the time we don't encounter these vessels over here, but the possibility is there of encountering this vessel, the communicating branch. This is always there. In the L5S1 region, this communicating branch is inside the canal. So this is another, although it is very rare, but you may encounter when we go in the L5S1 region. And the biggest issue with this intraspinal artery is that it is difficult to control this bleeding. If you cut this artery, then it is very difficult to control that bleeding, because the artery will retract, it will go behind this lamina, and it is very difficult to see that bleeding part of this artery. Artery of Edenkovic, we all know all about this artery of Edenkovic, which is a reinforcement branch which mainly comes from the T9 to T12 region. That is the entry of this artery of Edenkovic, which is the major supply of the anterior spinal artery, and it basically supplies a major segment of the spinal cord. Fortunately, this is more commonly in the upper part, in the thoracic region. Very rarely we see it in the lumbar region. Maybe in just 5 to 10%, 5% cases, maybe we can see this in the L1, L2 region. There's another artery which is called a Gordon artery. It stems from the interiliac artery, and this artery may comes located between L2 and L5. Very rarely we see this artery. This is just on the when I was searching about this literature, that time I found this artery. I never heard about this artery.
Most of the time it is located on the left side.
Which is a Goddard on
No, the artery of Adamowicz, I think most of the time it's on the left.
Yes. So can we strengthen